Good afternoon. And today I have an honor to interview my dear friend, cardiologist, Dr. Regina Druz. She is actually a CEO of Holistic Heart Centers. And as a dentist who treats sleep apnea, she's my colleague who I always go to because most of my patients have also high blood pressure, atrial fibrillation, so different type of cardiac disease, and high cholesterol, goes always with it. So, and a good afternoon, Regina.
Thank you so much, Maria, for the intro, and thank you for having me.
And thank you very much to our audience. If you have trouble sleeping or sleep next to the snoring partner, this program is for you, because usually that's the sign of sleep apnea, and most likely high blood pressure not too far from you if you have this disease. And if you're a medical professional who, just like us, trying to put puzzle of this dangerous disease of modern age together, this program is going to be for you, because we're going to talk about different approach to cardiac health. Now I'm going to introduce you, my dear friend, Dr. Regina Druz. We actually met through Synergy. Her name was mentioned to me, and then I reached out because I was fascinated with the approach, with the cardiac treatment approach she offered to her patients. But in addition to that, she's integrative cardiologist, and she's creator of Fit in Your Genes. We will find out more about that. That's the program based on the functional medicine for patients who want to optimize cardiovascular health, wellness, and vitality. And she completed her medical degree in Cornell University. We love this university. My son graduated from that. And she's board certified in cardiology, cardiac imaging, nuclear cardiology, echocardiography, cardiac CT. And she's a national expert in cardiology. And she had a lot of leadership position. So my first question to you, Regina, would be, what actually a true story about cholesterol? Because when I was looking through your reels and videos, and you mentioned what even Egyptian mummies have plaque in the brain, in the vessels, in the arteries. They didn't have perfect cardiac health, and they did not have a processed food. And can you please start with that conundrum?
So it's a great question, Maria, and the answer differ depending on who you listen to. But perhaps I can give you listeners an easy way or an easier way to think about it, right? When patients often, or we as adults, when, for example, we go for a physical and we get some blood work done, and a doctor tells us, well, your cholesterol is either high or a little high, you need to do diet, or maybe you need to go on a medication. It tends to be presented by a medical community as the only thing that a person must fix, or they're going to drop dead of a heart attack or a stroke. And so, number one thing here that your listeners need to know is that I consider this a type of medical gaslighting, right? Because the real story is not like that. Yes, cholesterol, especially if it's abnormally high and provides certain cholesterol influences on the blood vessels, and those are not necessarily coming from one specific cholesterol, but cholesterol and lipids together are what we call a lipidome, right? And there are different types of that lipidome. And of course, depending on what a person's lipid type is, there could be a negative influence on their blood vessels. But we know from the studies that were done across many different patient groups that even with a perfect cholesterol, let's imagine that cholesterol is perfect in all measurements we can think of. Even with a perfect cholesterol, the risk of heart disease is only reduced by 30%. We call it relative risk reduction. And I always tell my patients, well, what about the remaining 70%? So in cardiology, it has a very interesting name. We call it residual risk. But how can 70%, which is so much, actually be a residual. So the way for your listeners to think about it is to ask yourselves that question. If my cholesterol is elevated, what is my risk of heart disease, specifically heart disease events? Because people may have heart disease, for example, calcium scores, but they haven't had an event. They haven't had a heart attack or a stroke or anything heart related. So that's a question number one. Question number two, if my cholesterol is elevated, and even if it's not, because up to 75% of patients with first heart attacks have normal cholesterol levels. This is just the statistics, right? What is my vascular risk? Not just for the heart, but also for the brain. And number three, if my cholesterol is elevated or if my vascular risk is elevated, what are the reasons that this is happening? And the reasons are typically have to do with things that are not immediately visible and they require workup. Is there inflammation going on? Is there oxidation going on? Does the person have any toxic exposures or dysregulation of their immune system, right? You know, is the metabolism off track, which is commonly happens in adults, especially as they approach middle age? Are the hormones out of whack? So these are not traditional cardiac risk factors. These are mechanisms, these are root causes. And in those situations, cholesterol, which, and part of it is genetic, of course, cholesterol serves, it's a red flag, right? Your system, your body is waving this red flag and says, hey, come over here, help me. Something is wrong. And so what the doctors are doing, they're telling you, oh, you know, this red flag, take a statin drug, but they're not really giving you a way to look beyond that to straighten out the reasons why you have the red flag in the first place.
This is a beautiful, beautiful story. And I know you work with people to help them to avoid statins. And I want to ask you, what actually the rule 40, 30, 20, and 10, and how you use it to personalize? That's a very hard question. Lipid lowering strategy for different patients.
So great question. And thank you for listening to some of my videos where I talk about 40, 20, 20, 40, 30, 20, 10 rule. So what is the 40, 30, 20, 10 rule, right? First of all, it's important to understand that in cardiology and in medicine in general, most of our knowledge is not coming from looking at one person. Most of our knowledge is coming from studying populations. And that makes sense because when we study populations, which are groups of patients, we could get some insights that we can then apply to down the line. The problem with this approach is that a person in front of us may not be similar to a population that was studied. But this is the best we have, you know, and in personalized medicine and precision medicine, we continuously try to translate these lessons that we learn from large group of patients, from populations, and see, does it actually fit with the person in front of us? So the 40, 30, 20, 10 comes from what we learned from those population health studies. And what we learned from those population health studies, when we put all of these studies together with regard, and the studies were specific with regarding the statin drugs and their impact on lowering cholesterol. What we learned is that there is a relationship between the level of LDL lowering and impact of that lowering on total mortality and cardiac mortality. There is also a relationship between LDL lowering with medications such as statins and the impact on a relative risk. And I will explain what these things are. So we know, for example, that in the studies that use statin medications, for every 39 milligrams per deciliter reduction in the LDL cholesterol, and I rounded up to 40 just to remember it a little easier, there was a 16% reduction in cardiovascular mortality and about 8% reduction in all-cause or total mortality. And I rounded these numbers to 20 and 10. right? So you can remember 40, 20, 10, which means in the studies for 40 milligram per deciliter drop in LDL cholesterol, there was a 20% reduction cardiac mortality, 10% reduction total mortality. And like I said before, the numbers are slightly different, but if you remember 40, 20, 10, you'll be in the ballpark. But what we also know is that if we look at all the studies across the board, with regard to LDL lowering, and most of the studies, and I know some of your listeners may say, well, what about ApoB? What about other, lipid markers? This is a complex discussion. In these studies, majority of these studies were done using LDL cholesterol because it was a measurement that was easy to obtain, and that's what was obtained, and that was used in the studies of drugs and other things. So, most of the literature we have is LDL cholesterol, right? LDL cholesterol usually parallels the ApoB elevations, although we know that ApoB, for example, is much more predictive of events than LDL cholesterol. So we use LDL cholesterol as a surrogate. That's what was studied. And so what we know from clinical trials across different patient groups, whether it was so-called primary prevention trials, meaning that those patients haven't had any cardiac events yet, right? They just had high cholesterol, or whether it was secondary prevention, meaning that patients already had their heart attacks and now they were treated, or even high-risk patients. LDL reduction leads to a 30% relative risk reduction. So the relative risk reduction, and that's the 30 in 40, 30, 20, 10.
Mhm.
What is relative risk? And this brings us back to the population analytics, right? If we have two groups of people and we say that in one group of these people, group 1, for example, there was a certain rate of cardiac events, and then we gave our group 2 a medication, let's say a statin drug, and we saw that event rate decreased, the relative risk reduction is the difference between the groups, right? So between these groups, the relative risk reduction was 30%, because the first group that didn't get any medication, it's not like they have an event rate of 0. They still had some event rate, right? It's just with a drug or with an intervention relative to that control group, the outcomes improved by 30%. And so that always brings me to a question. In my patient who is in front of me, how impactful it will be for them to lower cholesterol, number 1, how impactful it will be for them to lower cholesterol with a drug, number 2, and number 3, is there a way for them to achieve number 1 without doing number 2? Or if they're doing that number 2 and lowering cholesterol with a drug, can we find a way to use the lowest amount of drug that we need? And we call this concept ALARA, which stands for as low as reasonably achievable, right? And I spend a lot of my early career doing cardiac imaging. And when we do cardiac imaging, sometimes we use radiation, right? We use radioactive isotopes, or we use X-rays to image the heart. And so the guiding principle in cardiac imaging is always to give the lowest amount of exposure to a patient. So as low as reasonably achievable is an overarching concept. And this is exactly what we try to do. We can, stabilize the vascular lining and improve person's vascular risk, and use surrogate endpoints such as cholesterol or lipid markers, and do it as much as possible without using the medications, because we know that medications are not really fundamentally addressing the risk factors. They have a role, but they're not fundamentally addressing the reasons why a person is having what they're having.
I want to mention to my audience, if you or your relatives put on statin, please get on Dr. Regina Druz Holistic Health Center website and get in touch, listen to her podcast, and, listen to all the information she put online. What maybe it's the way to address the statins without medication for you or for your loved one, So I think it's a very important point because, obviously most of the patients are on a drug. I wouldn't blame the doctors for that because even, in my field, people always looking for unicorn. They're going to get the pill and they're going to get healthier. But I want to ask you last question. Please tell me, how is it possible to lower cholesterol and risk without medication? What actually you offering to your patients after you establish what that is possible? Because, obviously maybe it's not always possible, but if it's possible, what do you do?
Excellent question, Maria. And, you're right that it's not always possible. And, I want your listeners and viewers to know that sometimes in certain cases, it is not reasonable to stop the medication because instead of decreasing the risk to an individual, that would actually increase it, right? So there is a continuum of risk and many different situations. But our approach is to find each person's lipid type. And so the lipid type, you can think of it as a combination of influences or root causes that explains why their cholesterol is elevated. So for example, some of the common little lipid types include cardiometabolic, where we see elevation of cholesterol due to insulin resistance. Insulin resistance is very common. In fact, insulin resistance is one of the hallmarks of middle-aged and more senior adulthood, right? It's a hallmark of aging in many ways. And this particular pattern where cholesterol is elevated, and for example, we very often see elevated LDL cholesterol or elevated ApoB, elevated triglycerides, and low HDL cholesterol. That's sort of a clue that a person may be having insulin resistance. We call this pattern cardiometabolic. And very often in this situation, we can actually improve the cardiometabolic pattern by helping an individual to establish or reestablish insulin sensitivity. And very often this is done through a combination of nutrition, supplements, exercise. We use some digital biomarkers for that allow us to measure how well people are responding to some of these nutritional strategies. And so this is very helpful in guiding us forward. So one of the common lipid types is this cardiometabolic lipid type. Another very common lipid type, and it seems to skew a little bit more toward women, especially women in perimenopause and menopause, are the hormonal changes, right? Very often when women enter this stage of life, they develop, some issues that have to do with sort of immunity, like thyroid issues. Certainly their hormonal balance changes. Sometimes they go through estrogen dominance and then the hormones go down. And of course, insulin resistance rises. There is weight gain. There is accumulation of internal fat. So very often it is that hormonal type that we need to unravel, right? We need to balance the hormones. And again, women seem to be dominating this lipid type because of perimenopause and menopause, but it happens in men as well. It's not that it doesn't happen in men. It's just for women that seems to be a specific issue, which is an age-related issue. So that hormonal type is very important, and so that another lipid type that is better addressed by establishing hormonal balance. And hormonal balance in and of itself is a huge topic of discussion, as opposed to just giving women a statin medication. Another lipid type that we commonly see is so-called lean hyperabsorber phenotype, right? So there are individuals, and a ton of them are in the internet, YouTube, and podcasts. I'm sure people could point to one or another, but they're definitely a group of individuals. It's not the majority, it's the minority, and they tend to be younger, and they very often tend to have no evidence of coronary disease, not even subclinical. So very often their calcium scores are 0. they happen to be so-called hyperabsorbers. So they have low body mass index. They're lean and skinny, and everybody sort of wants to be like them. But when you get their blood work, you say, oh my goodness, what's going on here? And so they happen to be people who are absorbing a lot of cholesterol from food, a lot of fats from food. And so a lower saturated fat diet or rebalancing of their macronutrients actually works for them, right? So as well as improving their skeletal muscle mass. Some of these lean hyperabsorber lipid types have genetic predispositions and some do not. It's more of a phenotypic situation. But what does work for these patients actually is increasing the complex carbs as opposed to decreasing them, which is what they tend to do in the first place, right? And it sort of backfires, right? They start eating more fat and decrease the carbs, and their cholesterol shoots up like crazy. So the reversal of that will actually work for them. And so those are some of the common sort of phenotypes that we very often see. We see this cardiometabolic phenotype. We see the hormonal lipid type. We see the lean hyperabsorber type. There are, of course, so across these types, I just want to mention also the other one that we see commonly is the one which actually is hereditary. So a lot of patients say, well, my cholesterol, there is nothing we can do about it. It's genetic. Genetic plays a role for everyone. But the question is how much, right? And so we have a group of patients whose lipid elevation, their lipid type, is really driven by genetic variabilities. They are not lean hyperabsorbers. Their hormones are fine. They don't have cardiometabolic influences. They just have a combination of genes that makes them overproduce lipids, right? And there are different types, there are different subtypes of this. And again, a lot could be done for these patients with nutrition and supplementation. It doesn't always mean that they must be on a drug, but I can tell you that from our clinical experiences that it is definitely harder to achieve optimal balance without medications because depending on the degree of genetic influences, sometimes lifestyle interventions, they fall short.
No, I love it how, not one size fits all at all, how customized cardiac health should be. So I highly recommend to my audience to get in touch with you and find exactly if they have this problem, how it can be addressed in personalized way. So thank you very much. And you can find, I just mentioned, and we're going to put information about Dr. Druz and Holistic Health Centers underneath this interview. So thank you very much, Doctor.
Thank you, Maria, for having me. And I hope your listeners found this helpful. And we offer something called Heart Well Discovery Call. So if you want your heart to be well, it's completely free. It's with one of our patient coordinators, and it could give you some valuable information as to what to do next for your heart health.
Thank you.